Okay, this is going to be a really fun edition of Plastic Surgery Untold. It is my pleasure to introduce a guest, Heather King. She is a breast surgeon with whom I've had the pleasure of working for many, many years. She treats women with breast cancer, and we're going to talk about a very interesting topic, and that is nipple sensation sparing, nipple sensation preserving approach to treating women with breast cancer. And so maybe we'll just start it off and ask if you can give us sort of a comprehensive yet simple discussion or introduction to what that means.
Sure. Thank you for having me. I'm so
Yeah.
excited to be here with y'all. Um, Typically, when women go through mastectomy, they're numb across their chest. And as plastic surgery has advanced reconstruction, breast surgery has followed along. I think that really facilitated our field. And so now we can preserve the entire skin envelope and including the nipple, but women were still numb. And it leads to a lot of problems. It can be dangerous. Um, if you can't feel temperature and you're cooking, we've all seen exposed implants and stuff from burns. It's pretty rare, but it does happen. And I think for women, they will talk about how strange it is to hug someone and you can't feel it. And so it's, things were looking good, but not feeling completely normal. And so then we have some colleagues who developed this technique where you can identify the sensory nerves and restore sensation to the nipple. And so we started doing this here in Austin a couple years ago, and our patients are coming back and they have sensation. And some of them don't even know it. And I think it's because it feels so normal to them that they
No, that's a
just,
really interesting point I had not considered.
yeah, I
Yeah.
had one patient, she said, I mean, I don't know if I was like, can you, do you have sensation? What do you think? She's like, I don't know. I don't think I do. I said, well, let's lay back. So had her close her eyes, did the testing. And she's like, oh, I do feel that. And she sat up and she kind of was like, oh. And I said, well, I think it just came back and it was so natural. You just didn't even
Yeah.
think
That's
about it, which is,
exciting.
Yeah.
yeah. So,
And I think this is super exciting because everyone that listens to our podcast, typically we're just talking about aesthetics, but this is really where the world of reconstruction and aesthetics has started to merge and
yeah.
evolve, like Dr. King is saying. And in your other life, when you're not at Austin Plastic Surgery, you do a lot of microsurgery, breast reconstruction, some really technical, skilled stuff, and
Mhm.
pretty cool that you guys do these surgeries in combination. And like Dr. King saying, I am always just enamored of the subspecialty and techniques and stuff available in a city like Austin. And Yeah. the amount of subspecialists and unique procedures that are available to our patients here is great. And that's why you decided to have Dr. King here to highlight some of the cool options that people have, whether it's aesthetics or breast
Yeah.
reconstruction. And that really, I should say that Heather does deserve, Dr. King does deserve to be highlighted because there are several techniques that while they weren't entirely new, to our country or to some extent even Texas, she really did introduce the community to it, and other surgeons followed. And the rising tide brings all boats up, and I think that women in general really are getting a wonderful level of care, and this nerve, this sensory preservation, sparing approach to mastectomies and how I contribute to that really is one of the best examples. And we have a really savvy, yet sometimes, or let's say mostly non-medical audience. And so I thought it would be helpful just to briefly discuss in basic terms the anatomy of the breast and the sensation that goes to the nipple. And I think if you'd like to do that, there'd be no one better than you to kind of briefly
sure.
discuss that,
Mhm.
and then kind of perhaps discuss what you do, and then
Yeah.
I can discuss sort of how I contribute to that process.
So I always describe the anatomy to patients when they're newly diagnosed, and I draw a kind of a breast and I tell them imagine cut it in half, which they're like, ugh. But there's skin, there's subcutaneous fat, and then there's the gland, and then that sits on your chest wall. And then most of the sensation to the nipple is coming, the most of the times the nerves are coming from outside kind of the borders of the gland, and they wrap around and then they innervate the skin above them. Some people will have nerves that come through the chest wall between the ribs and go in through the gland, but most of the time it's on the side. And so if you're paying attention, when I go in, I try to stay right on that plane right above the gland and leave all that subcutaneous fat under the skin unless it's involved with cancer. And then That preserves the skin so that Dr. Weinfeld can do a beautiful reconstruction and we can minimize scars. And then if you can see that nerve, you can follow the nerve. And it's very important to understand that I don't compromise. If it's a woman with cancer, I do not compromise the oncologic safety of the mastectomy. I follow the nerve. I dissect it as far as it's safe and as far as it's usable for Dr. Weinfeld, because sometimes they get too small or they fork.
Yes.
And then that's where I divide them and mark the nerve for him. And then he's able to take that nerve, the native nerve, and put in a graft and plug it in behind the nipple and slide the expander, which eventually, or the flap. And I mean, we're talking about volume replacement. So I always tell patients a reconstructed breast is not going to be the same as your natural breast.
Mhm.
It's not. It's not going to look the same, but we can get you looking really good. Sometimes we get you looking really better.
That's true. Yeah.
Um,
Especially with that large A, B, C population, sometimes after childbirth,
Yep.
the breasts have sagged some. And with the implant, we can reverse some of that sag.
For someone that's a little bit removed from the breast reconstruction world, can I give you some rapid fire questions that have popped up that I maybe don't are a little removed? One is this: so this sounds like it can be done in both a prophylactic mastectomy, so someone who doesn't have cancer, or someone that has cancer, depending on the right situation.
yes. Yes.
And then, like, is this something that patients would ask you about? Is this something you do for everybody? Is this something you discuss with them? How does that process go?
I think patients don't necessarily know to ask about it yet.
Mhm.
It's pretty new.
That'll change.
Yeah. And I want them to ask about it. And what was the second part of that
No,
question?
just how do you decide who's a candidate for it? Or
Oh, you have. So we have really stuck to women who are good candidates for nipple-sparing mastectomies.
Mhm.
So those patients are usually 65 and younger, smaller breast, and you can't have a lot of comorbidities, no smoking, poorly controlled diabetes, obesity. So, a relatively healthy individual with a medium to small size breast. Now, I've done nipple sparings on some very large breasts, and we've been really happy with it. I think as Dr. Weinfeld as we explore this more and more, we've talked about innervating deep flaps, and that could be useful for women who aren't a candidate for sparing the nipple. Maybe they just have a skin sparing mastectomy.
We did a fair amount of that in Ohio State,
Mhm.
neurotization of the flaps.
Yeah.
And what about if somebody didn't get this done? I'm assuming, but I don't want to assume wrongly, that it's kind of needs to be done at the time, because then it's really difficult to find those nerves and stuff if it didn't happen at the time.
Actually, we were just having a
Yeah.
little meeting last
Yeah.
week and talking about what do we do for all these women who had surgery prior to our experience with this.
Yeah.
And
That's the
I
next horizon. Yeah.
I think it would be awesome. I think you can go back and you can find the nerve root, and then they would have a longer graft because Dr. Weinfeld's using a little graft.
Probably use like a sural nerve graft or something along those
Well,
lines.
actually, yeah, I wanted to. I'm glad you asked that question, and I wanted to. When Dr. King mentioned a nerve graft, I wanted to briefly, for our audience, discuss what that was.
Right.
In medicine in general, in surgery in general, plastic surgery in general, when we talk about a graft, we're talking about a tissue that is like the tissue that it's replacing, but came from somewhere else. And like Dr. Arredondo just mentioned, there are nerves in the body that are acceptable donor sites. They don't cause problems, not significant problems, to borrow them and transplant them somewhere else as a graft. In this particular case, what we're doing, for a variety of reasons, which we don't have time to get into, we're using a cadaveric graft. So what I tell the patient is, this is someone who passed away and they wanted to use their body to help other people who are still living. And in this particular case, what they're doing, the company, shout out to Chad DeVille, is doing is they're processing these nerves in a minimal way so that they serve essentially as a bridge between the nerve root that Dr. King has dissected out and either a nerve in the nipple or the skin directly in the nipple. And so that's the graft situation. You're right. If we need to do longer segments, replace longer segments, longer gaps, we're going to have to think through, how do we go about that? And I still think, for simplicity's sake, and also for patient acceptance sake, we're going to have to use cadaveric nerves, or at least we'll tend to use cadaveric nerves. And therefore, We have actually, with some of the larger chested patients, we have put two nerve grafts together. And I don't know the limitations at this point, but it is also possible that we will be able to be supplied with donor nerves that are longer. Remains to be seen.
So I have a question. So traditionally, with motor nerve reconstruction, you've got a time limit. But with sensory nerves, it's a different story.
It is
So
entirely.
all these patients that have been operated on years ago still could find benefit from this technique. Is that correct?
Absolutely. Yeah. The sensory organelles, the little tiny, the little tiny things in the cells, in the skin that create sensation for us, the little triggers, those have the infinite capacity to be reinnervated.
And what would be the natural course? Because immediately post-op, they're going to have some numbness in that nipple, and that doesn't mean a failure, because that's actually part of the process. But what's a typical time frame? And I know it varies on that distance and a few things, correct?
I've had recently patients come back 2 years. They have full sensation. And I have a patient who's about at 1 year and she had sensation. What I've seen as I test is that the sensation is kind of coming up, like up the mound of the breast, just kind of, and you can imagine as the nerve is regenerating through the graft that the sensation is following it. And so it's going to come up to, and then they're going to be, I can feel.
It's exciting and kind of, the anticipation. I feel like back, when I was a little kid waiting for Christmas, you're kind of waiting endlessly like, there's some good stuff at the end of the tunnel, but it's just, I think there's a little bit of patience and time, unfortunately, because sometimes people wake up and they're like, I don't feel anything. And you're like, right, but it's coming.
Yeah. And I to just put a few little numbers to it, generally it takes about a month for the nerve that has been cut to kind of do its thing and start growing. And then it's about an inch a month, although, it could be slower. And I don't think patients could be discouraged because, as Dr. King mentioned, we are seeing some of that recovery, really important sensation recovery, and the nipple even further out.
Right.
How would patients, if they are interested in this, how do they go about finding a breast surgeon, plastic surgeon that does this? Because this is pretty novel and not, and I'm not discrediting anybody, but not everybody does this type of procedure, because it does take a tandem approach of both a breast surgeon and a plastic surgeon that are into this, willing to work it, because it is a little bit more time. It is a little bit more effort. I think you're not giving yourself enough credit for the technical skill of following out a nerve, the time delay in terms of like slowly wheezing that out. It's easy to just kind of go and just blow through everything. And it is a very meticulous process to get those nerves, preserve them. So Dr. Weinfeld has something to put back together instead of just shredded pieces.
Right.
Yeah.
Fortunately, as I've done more and more of these, I've gotten quicker and more confident. And while I was learning about it and before we went and did the training, when I was doing the lateral dissection and taking the breast off the chest wall, I was looking for them. So I was kind of training my eye, not just to, oh, there it was. There it is.
Right.
Before
Once you see it, it's like hard to unsee.
Correct.
Yeah.
And you're like, oh, we can do something with this.
Yeah. And
So,
it makes you think back. It's like, oh, I didn't see that before.
Yes.
Now I want to go back and help
I
all
want to
these
fix
women.
it. Yeah. I think that patients just need to ask, and they just need to ask how often they do it. What is their technique?
You have such a robust practice because of the skills that you have offered the community, and I'm presuming, because I don't see all of what goes on in terms of how patients come to you, but I presume that we are in the phase where patients are coming to you for mastectomies, for incredible cancer treatment, and you're offering this to them. But I think we're on the precipice of patients really seeking you out, seeking us out as a team to deliver this.
Right.
And we've got a long track record of this relatively in Austin. And you're starting to see some really fantastic results in terms of achieving that sensory recovery. And so I think we're really going to start to see that, because in these communities of people who have a similar and challenging disease, we know that there are networks that sometimes we don't even have access to, where there's a lot of really positive, supportive discussion. So I know we've all talked about this. It's just going to happen, and we're going to help facilitate that from an educational standpoint. But also, we can just sit back and allow our work to speak for itself.
Right.
And patients that have had, that you mentioned, or that have had nipple-sparing mastectomies but didn't have this nerve technique, they could still come see either you or Dr. Weinfeld for a consultation, and you'd kind of help them funnel whether they're a good candidate for that or not, and then what the options would be. Because I feel like there's a lot of people listening. They're like, "Oh, this is cool," and we have some of it that like the technology just wasn't there, or there wasn't a good place for them at that point. And so I think this is super interesting, and just want to make sure people can get to the right spot to at least ask the questions.
Yeah. We're getting close to the end, and so I want to do two things. One is I want to ask Dr. King, are there some things, we were so looking forward to this, and are you really excited about it to the extent that you really said, hey, we should do this, and we really wanted to?
You're going to do this.
Are there things that you feel like you want to make sure that our audience knows about before we have to kind of wrap things up, like things that will really help patients?
First of all, get your screening mammograms, please. Second of all, not everybody has to have a mastectomy. This is not always, it's a choice. It's a very personal decision. And not everyone would be a candidate for this procedure, as we talked about a little bit. So I think you just have to understand especially if it's a woman who's just diagnosed with cancer, and understanding what her surgical options are, and know that maybe this isn't the right operation for you, but there certainly might be other operations that are going to give you a beautiful aesthetic outcome. That's always my goal, but also cure your cancer.
Right.
And
that's the foundation of what you do.
Right. So, and not all of my patients have beautiful scars, but man, they're survivors. They beat cancer. And I want to instill in them a sense of pride about their scars. But if I can make them feel totally whole and feel good naked and look in the mirror and not be traumatized, that makes me feel good.
You know what I did? I kind of miscalculated things a little bit because we didn't really start right on the hour, and I was looking for that 20-minute mark. So that, I think, leaves time for something that Dr. King was looking forward to. Don't want to put her or Dr. Franco on the spot, but I remember you said something about rapid-fire questions at the end. You guys ready? Should we do this, or do we want to do something else, perhaps with the next couple of minutes?
Are you going to fire some questions at her?
Well, but I'm a little bit, in some ways, I'm a little bit biased. I might not ask at the level that's important because, again, I try to be mindful of who our audience is. And again, they're really savvy, but most of them are not medical. So that's why I thought, given that you're a little bit remote for it, and maybe Dr. Arredondo too, could do some sort of rapid fire questions, and I can help answer too, maybe from the reconstructive standpoint.
Phone a friend.
Yeah.
Phone a friend.
And I think you answered a couple of the big ones. Was one, can you tell people what is your website? What's the best way to get a hold of you if they have questions about this?
Call my office and make an appointment.
So they would just be Dr. Heather King.
I want to see Dr. King.
Do we want to announce the phone number?
Can I?
Yeah. Oh, yeah. This is
your world.
Yeah.
Oh, okay.
Yeah. We make the rules.
512-421-4111. And if you go to Texas Breast Specialist, you can find me. And I think they now have a link to make an appointment online. Don't hold me to it. I know they're updating our website, so don't hold me to that. You can call and get an appointment.
Yeah. And that's Dr. Heather King, MD. Austin, Texas. And here's another important thing to mention, because we have an audience that is kind of regional and even national. We definitely have patients come from far out in Texas, and in some cases even other states. And we have a lot of supportive systems that we can help make that possible for patients, that they can come here to get this really high level of care.
Here's another question, and not to put you on the spot, but how about insurance? Is this something that insurance covers during an initial mastectomy? If I've had a mastectomy reconstruction, I want to come back because the nipple sensation is something that really was meaningful, because I think we danced around a little bit. No, one, there's a protective sensation, but also for a lot of poor people, it's important in intimacy, and I think that's something that can be important. Is this something that insurance typically helps cover? Is that still a gray area? Is that still dependent?
Slightly gray. Yeah. We've had some insurance companies kick it back. We've had some, it's been no issue, and we're trying to sort that out. And I've definitely done some peer-to-peers to support doing the procedure in my patients, and it's really...
I want to ask a rapid-fire question of myself, just because I think it's actually important to get this out there. So, Adam, Dr. Weinfeld.
yeah.
I'm on a first name basis with myself.
With yourself.
So, Adam, what are the benefits of this? Why are we doing this? And Dr. King already mentioned this. There's protective sensation. Dr. Franco also mentioned that there's the, erogenous or intimate sensation that's also important for many women in normal sexual function. And there's also a preventative effect of this as well. When a nerve is not reconstructed, it does try to grow, and it can kind of get caught up and create a little ball that we call a neuroma, which in essence is like a little pain button sometimes if it's not protected, let's say, by the breast tissue, if it's further out and there's only skin over it. So if you give a nerve a place to go, i.e. a graft, even if it doesn't make it to its destination, it doesn't form a neuroma, or it's less likely to. So there's also a pain management aspect of this, which I wanted to make sure that we got out there for the population.
All right, I have 2 questions. So let's say a lot of our women on listening to the podcast are considering or have had breast augmentation. Are they still candidates for this procedure?
Absolutely.
What about if they've had a lift or a reduction?
We've done it in patients with
Yeah,
lips.
yeah. Because a lot of those procedures don't actually go out far enough to the side of the body where it interferes with that nerve. And then also Dr. King and myself, sometimes if it has, or even in patients who have a little bit different anatomy, we'll start to search underneath some of the muscles where we know the nerves to be.
And this sounds like this doesn't really add much meaningful recovery length time stuff to the patient themselves.
No.
No. And I find they actually have a little less pain.
Yeah. Yeah. And I will say it did used to take us a little bit longer to do some of these surgeries. But and that was just kind of getting through the logistics of, what supplies do they need to have available? How do we need to get them ready? What the sequence is. But I will say in our last couple of cases, it didn't take any longer than the nipple sparing mastectomy reconstructions with implants that we were doing prior to this.
So as of today, how long have you been practicing breast surgery?
9 years in Austin, 10 years since I finished fellowship.
And how long have you been doing this newer procedure?
2 years.
Yeah, yeah. And we even have one patient that we kind of did before we hooked up with Chad DeVille, before we went and visited the Pleds. And that was probably like 3 years ago, just based on your desire to do it and your knowledge of what was going on out there. Yeah.
Right when
Yeah.
COVID started.
But this is awesome. I hopefully you'll come back, because we were talking about. I definitely would love to expand and do some more breast reconstruction topics. We were talking about, that's a whole, kind of series, and maybe we'll talk you into putting something together. But I think there's so many questions we get. You've been a huge resource to our practice. I know sometimes when people have something abnormal on their mammograms, their stuff, we send them to you for your expertise, and you tell us whether you need to do something or whether we're okay to proceed. And so I sincerely appreciate all your help of us taking our calls and helping our patients get to a good spot before their aesthetic surgery too.
Yeah, very special thank you. Thank you for being here.
Absolutely.
Thanks for having me.
We'll see you guys. Plastic Surgery Untold, greatest podcast in the world. Don't forget, check her out, Dr. Heather King here in Austin, Texas. But honestly, anywhere from Texas comes to see her all the time. We'll see you guys. Bye.
Bye.
All right. Bye-bye.